Thanks, Lynn. Thanks for having me. I'm grateful to be here, and I'd like to say that I think Jonathan Welch's presentation is call for patient involvement through the prism of his own painful personal experience and the comments we heard after segue nicely into the presentation I want to make. I come to you not as a medical professional, but as a survey researcher. Public opinion research is my field. And the purpose of the research we do is to bring the voice of the public, in this case the voice of patients, to the table. Exactly the goal that we're hearing discussed so far this morning. So I'm grateful for the opportunity to bring these voices to you in the quantified form that we do. I'm grateful also not only to the IOM, but particularly to Blue Shield of California Foundation, which has sponsored and partnered in this research with my group over the last few years, conducting a high-quality, rigorous survey, public opinion surveys of low-income Californians to understand better their experience of care and the motivators of their empowerment and engagement in the healthcare system. I'm going to talk to you a little about this. The research program we've done with the foundation is based on statewide surveys, telephone surveys, landline and cell phone of a random sample of low-income Californians, those at less than 200% of the federal poverty level, the safety net population, if you will. The notion is that the ACA is going to introduce competitive forces within the provision of care to this population. Providers need to respond. So in spring 2011, we did a baseline survey of the experiences and preferences of this population to learn about the drivers of patient loyalty and satisfaction. Two drill downs emerged from that, two facts of that first line of research that we thought were interesting and needed further exploration. One is the expressed desire among these patients for a regular personal doctor. The primary interest of theirs was that they wanted to have one of those. The second was the substantial and perhaps surprising to some resistance to the concept of shared decision-making as we tested it. So we conducted additional survey in spring 2012, a year ago, to explore these and other potential drivers of patient empowerment and engagement. Connectedness and continuity is the concept that we came up with that really seems to drive the empowerment and engagement of patients, particularly in terms of relationships. When you ask patients what they want in their healthcare, they say they want a regular personal doctor. There he is. What came to us as we explored this theme in additional questioning, what patients are doing is they're using this concept of Dr. Welby to describe really the most familiar route to their real aim. Connectedness, a sense that someone where you go for care gets you, knows you pretty well. And continuity, the assurance that you'll be seeing the same caregiver over time. Connectedness and continuity, as I will present this morning, drive patient engagement, patient empowerment in a powerful way, above and beyond and apart from this simple presence of Dr. Welby. Indeed, wanting but lacking a personal doctor independently negatively predicts satisfaction with care and patient loyalty. But when connectedness and continuity, as I've described them, are present, are added to the equation, they independently positively predict satisfaction, empowerment, engagement alike, and having a regular personal doctor does not. Falls out of the equation. Okay, so we said, as I mentioned next about, that's the regular personal doctor. Then we looked at shared decision making. And we were kind of surprised by this result. Among this population, about 6 in 10 said they'd like an equal say in decision making with their care provider. That is frankly fewer than you might expect. Coming from the prism of a educated, involved base, you would expect an overwhelming majority, 8 in 10 or more perhaps, at least I did. But a fairly substantial minority, 4 in 10, said no, they preferred to leave decision making up to the care provider. Now, what was that about? Well, we asked a few follow-up questions, but one was, what if the doctor chose options for you and explained them to you in information that you could clearly understand? Would you then like to have an equal say in decision-making, and you can see what happens? The role of information in decision-making is a powerful factor in sign-up among patients to this concept. And indeed, it fundamentally levels the playing field. The blue lines show you the initial interest in shared decision-making, and we can see some significant socioeconomic gaps. Willingness to participate in shared decision-making is far lower among less empowered populations, less than high school compared to college grad. Look at those blue lines. Whites versus Latinos, non-English speakers versus English speakers, enormous gaps. Now, when you provide information, those gaps largely disappear. That information levels the playing field in terms of willingness to participate in shared decision-making. Again, a powerful example of the important role of information. Information, communication. All right, we take this information to, through a series of regression analyses, build a mediation model that predicts, lays forth a path, we call it, to patient-centered care, through a model of empowerment and engagement. This is what it looks like. Connectedness and continuity, as I've described them to you, the sense that someone there knows you and that you'll see the same caregiver over time, independently of demographic variables, having a regular personal doctor, health status, a place of care, insurance status, and the rest, independently predict empowerment. Empowerment meaning feeling informed about your health, comfort asking questions, comprehension and understanding the answers, and confidence in your ability to make healthcare decisions. Those empowerment measures, in turn, independently predict engagement, the sense that you're taking an active role in your own care, really the goal, fundamentally, of patient-centered care as we're discussing it. I will point out that information, the first empowerment measure, is a standout, a top item, because it also independently predicts the other empowerment measures we talk about here. I'm going to break these down a little bit to show you the impacts, the effects of these variables. It's really quite impressive, I think. Connectedness, predicting feeling informed about your health. Among Californians, low-income Californians who feel a personal connection at the place of care, 64% feel very informed about their health. Among those who lack a personal connection, it's 37%. An enormous impact or effect of that sense of connectedness. In terms of continuity as well, similarly, if you usually see the same provider, 56% feel very informed about their health. You don't usually see the same provider, that goes down to 35%. Again, a dramatic impact. Connectedness in terms of predicting our other empowerment indicators of comfort, comprehension, and confidence. If you're feeling connected, feeling someone at your place of care knows you well, you're vastly more likely to feel comfortable asking questions, to say you understand the provider's instructions, somewhat more likely also to be confident in your decision-making ability. Continuity has similar impacts. Among those who always see the same provider, you see a lot more comfort asking questions, a lot more comprehension of answers, and somewhat more confidence in decision-making as well. These are fairly powerful impacts. And then we talk about information and its predictive capability in comfort, comprehension, and confidence. And there it is similarly as well. Among those who feel very informed about their health, comfort asking questions of their provider, comprehension particularly of the provider's answers, and confidence in decision-making are all dramatically higher. Okay, and then finally, the sense to which each of these predict the outcome, the holy grail of patient engagement, or self-efficacy, if you will, in their care. These are the percentages of patients who report having a great deal of say in their own care. Those who feel very informed are more than twice as likely to say they're engaged in their care. Those who feel very comfortable asking questions, again, very substantially more likely to be engaged in their care. Those who understand the provider's answers, those who are confident in their decisions. In each case, each of these is a strong influence on the patient engagement. Now, one route to patient engagement beyond the regular personal doctor we discussed earlier is team-based care. And I want to describe to you briefly its impact on some patient sentiment that we see measured in this population. Among patients who have team-based care, the satisfaction with their care is significantly higher. Sense of information, and we've seen it's important, is significantly higher. And understanding or comprehension of the provider's instructions is higher as well. Similarly, people who have team-based care are more likely to feel there's someone at their place of care who knows them well, connectedness. I think the last three bars show it perhaps best. They're both positives and negatives from this stack. First, among private doctor's office patients, 51% say there's someone at their place of care who knows them well. On one hand, that's fairly devastating, isn't it? Only 51% of private doctor's office patients feel someone at their place of care knows them well. Clinic patients who are in team-based care, however, match that population in their sense of connectedness. It's clinic patients who don't have team-based care who fall off the charts in terms of connectedness. So team-based care at least lifts clinic patients to the level of private doctor's office patients in the sense of connectedness that patients achieve. It's helpful in that regard. That's the positive. The negative is that there's still a lot of room for improvement. Okay, so our prescription for patient engagement then is that connectedness and continuity pave the path to patient empowerment and engagement, and that information is essential. It predicts self-efficacy even when, I'm sorry? Yeah, I beg your pardon. Information is essential. It predicts self-efficacy even when connectedness and continuity are held constant, and it does so more strongly than the demographic variables. Now, I'm going to wrap up. Just a last comment, and just a word about measurement. In doing this research, we do start with a review of the existing literature. And I know there are a number of researchers here or those who are involved in publishing on the subject. And as a survey researcher, I wanted to make a couple of quick comments about this. Attitudinal measurements in non-probability samples are not generalizable. Agree, disagree, and yes, no questions are inherently biasing. Unlabeled or partially labeled number scales often lack internal validity. And knowledge questions are problematic in an opinion survey format. I'd be happy to discuss these with anyone later, but there are many examples in the literature of the use of suboptimal approaches to survey research that I think could and should be addressed as we move down the road of bringing patients' voices into the discussion. Data analysis, finally, is enriched by rigorous modeling. Thank you very much. I appreciate it.